The neurosurgical case room. Am I audible?
Yes.
Okay. So, have you people reviewed yesterday's recording? No one? Because we did cover a significant part of the anatomy yesterday, we are going to start from where we left yesterday so that we can finish on time today around 8:05 or at most 8:10. Okay, who is writing in the chat box? Thank you, Dr. Shakir. Is it Dr. Shakir? Shakir or Shakiru?
Yeah, either one is okay.
Okay.
Well, the full
Okay.
one is Shakirola.
Where are you from?
Nigeria.
That's nice. So good of you to revise the yesterday's recording so that we can go heads on in the today's session. Let's start. I am sure all of you remember most of it. Let's just go briefly. So these are some important structures through which we will be coming across even today. This is, what structure is this? It's labeled pars orbitalis, right? And then we have the pars triangularis, and then we have the pars opercularis. These are the rami. And then there is this branch going on like this. I'm changing the colors so that you're clear. This was the, which ramus was this? The orange one?
Anterior rami.
Which anterior rami?
Horizontal.
Anterior horizontal, that's right. The orange one is anterior horizontal ramus. The green one is?
Anterior ascending ramus.
That's right, anterior ascending ramus. And the pink one is?
Posterior ramus.
It's the posterior ramus. So where's the stem? Where's the stem of the Sylvian fissure?
Stem is visible medially.
Yes, but stem is not completely visible. We know that the stem is going to go in this direction, but it's not completely visible. Why? Because the stem is at the inferior surface of the brain and in contact with the sphenoidal ridge. Okay, I also made this mistake yesterday of saying that it was the greater wing of sphenoid. It's the lesser wing of sphenoid that we rongeur off here, right, to reach the anterior clinoidal process. So I have made that correction in the comment box on the previous YouTube video, and I'm also reassuring this in the new video. So this is the sphenoid wing that we rongeur off. And once we rongeur off and we go deep in, this is where the stem of the Sylvian fissure is. Let me see if I can find that image. So this here is the stem of the Sylvian fissure, which has been opened, by the way. This is an image post the splitting of Sylvian fissure. The stem has been opened, hence you see such a wide view of the ICA, the MCA, the bifurcation of MCA, etc. This is the stem. The stem is at the inferior surface. It reaches the lateral surface at pterion. And on the brain surface, this region is called the anterior Sylvian point. This stem then divides into the anterior horizontal ramus, the anterior ascending ramus, and the posterior ramus. The posterior ramus was ending in
Supramarginal.
That's right. The posterior ramus was ending in supramarginal gyrus, and the superior temporal sulcus was ending in
Angular gyrus.
angular gyrus. So part of the superior temporal gyrus and supramarginal gyrus and angular gyrus, they all make up the vernix area, right? Whereas pars triangularis and pars opercularis are Broca's area. So Sylvian fissure is darkly connected with all the language areas. Hence, when we are splitting it, we need to be very careful regarding the retraction. What other structures are here that can be compromised during the retraction? There was a vein going over it, right? What was that?
Roland.
Which vein was this?
Superficial middle cerebral vein.
Okay, so what happens if we end up retracting this? What happens? There's another vein here, right? Somewhere here. Or maybe slightly anterior. What is that vein?
Vein of
Vein of
Labi.
Vein of
inferior
Labi.
anastomotic.
Yes, inferior anastomotic vein. We have the superficial middle cerebral vein here. Slightly posterior, we have what? Transverse sinus. Obviously, this is just an illustration. It's not an accurate diagram. But vein of Labi connects this to the transverse sinus. Superiorly, there is another vein, the superior anastomotic vein. What is that called?
Pollard.
Vein of
That's right.
Roland.
And of Trollard. So, when we are retracting or when we are splitting the Sylvian fissure, apart from the vessels, apart from the arteries, we also have to be careful regarding the veins. What are the important vascular structures, other vascular structures here? Which arteries around here?
MCA.
MCA. That's right. Yes. So if we are going to follow this tract, what is this region here? I think we briefly did discuss this portion. What is this?
ASP.
Anterior
Yes,
Sylvian port.
That's right. Anterior Sylvian point. So anterior Sylvian point is the region where once we start dissection and we open up the arachnoid and the cisternal region, we go down deep, we are going to find the MCA bifurcation. And also, this is going to be the superficial most part of the insula here as well. If you open this up, the background that you're seeing here, this cortex, this is insula. So I'm really happy that all of you have retained a lot of what we discussed yesterday. Also, Sylvian fissure is the deeper part of it is called Sylvian cistern. And then we divide it into two segments. What were those two segments?
Pinoidal
And
Opercular.
and
operating
Opercular
operating
insula.
segments.
That's right. So we have the sphenoidal segment, and then we have the operculo-insular segment. Now, the location is completely different. Sphenoidal segment of the Sylvian cistern is going to be around the base of the brain, whereas the operculo-insular segment is going to be between the two operculi and the insula. So while we are at the lateral surface, clear this portion is the frontal opercula, right? Then we go slightly posterior, this portion is the parietal opercula. You see that the Sylvian is continued here, whereas inferiorly, this is the temporal opercula. Frontal opercula is made up of
Pars orbicularis, pars orbitalis, pars triangularis.
yes, and sometimes parts of the precentral gyrus as well. Basically, all the lateral surface, this region, we are calling it opercula, right? And then we have the parietal opercula, which is made by postcentral gyrus, sometimes the inferior parietal lobule as well. So this is the parietal opercula. This is the frontal opercula. I want you to have a clear idea so that when we see the coronal sections, it's even better. And then inferiorly, we have the temporal opercula, which is made by the superior temporal gyrus and Heschel's gyrus. Heschel's is slightly in between. If we open this space up, then the Heschel is going to be here on the flatter side. And these are the two gyri from the temporal lobe, which are in continuation and in contact with the Sylvian cistern, operculo-insular part. If we open these up widely, what are we going to find? Anyone? If I retract these, am I audible?
Yes.
Okay.
Is it ICA, ma'am?
Insula.
Oh,
If we retract both of these operculi, we retract the frontal lobe superiorly, we retract the temporal lobe inferiorly, there's going to be insula behind it. This is the corridor that we use for reaching the basal ganglia. I think we did discuss this briefly, the Sylvian transinsular corridor towards the basal ganglia. Yes.
Insular flare I
Yeah.
can operate.
Move. This is the anterior Sylvian point, but we have discussed this yesterday. Let me move. So briefly going over this, spinodal compartment, we are going to look at the pictures again today. The roof is formed by the orbital gyre of frontal lobe plus the anterior perforated substance. The floor is formed by anterior part of planum polar with MCA. Now planum polar is a part of the temporal lobe. So you have this temporal lobe which goes like this. And this portion is most of it is made by planum polar here. That makes the floor. Superiorly, you are going to have the frontal lobe. Medially, uncus is going to be here. Laterally, slightly laterally, you are going to have the lumen insulae. Let's see the dissection images. So the anterior perforated substance, we know it forms the roof of the sphenoidal compartment. Then what is the extension of the anterior perforated substance? It extends from the olfactory striae and then it goes back. So there are the olfactory striae here and then it goes back. This is the optic nerves somewhere here. They make the optic chiasm. And now this is the optic tract. So this is the optic tract. Here we have the olfactory striae and the olfactory bulb. So this entire region, let me change the color so that it's clearer. This portion is going to be the anterior perforated substance. And what are we going to find here? On the medial side, obviously this region is going to have the interhemispheric fissure. Laterally, there is going to be lumen insula. So let's look at the dissection images so that it's clearer. Okay, now look at the same image. You see we have the optic nerves here. This is the optic chiasm. It goes posteriorly to form the optic tract. And here we have the olfactory bulb. Since we have the olfactory bulb, we have the anterior olfactory striae here and the medial olfactory striae. Then what is behind here? This is the uncus. Uncus is divided into two segments, the anterior segment and the posterior segment. The posterior segment is in communication with what? What is this here? Which structure is this? It's visible.
Cerebral system.
Sorry? This is in contact with cerebral peduncle. You see that this is cerebral peduncle here. Have you all forgotten the basic anatomy where do you people remember the Kernohan's notch phenomenon? No? Can someone tell me briefly what is Kernohan's notch phenomenon?
Madam, Kernohan's notch is whenever there is a compression, very severe compression, there will be ipsilateral weakness and contralateral pupillary dilatation, which is opposite of normal.
Yes, the weakness is ipsilateral, but why is it ipsilateral? What is happening there?
Because the pushing of the opposite side, like because so much of pushing, it pushes the opposite side of the tracts, long tracts.
That's right. So
Zero.
when there is compression over one side, this entire thing is getting compressed, and then this cerebral peduncle is going to compressed along the tentorial notch. So you have to remember the entire anatomy. We are looking at the inferior surface. We are looking at the inferior surface. If we flip it on, there is going to be tent here, right? So there is going to be 10th here. And since 10th is going to be here, what else is going to be here? Third nerve, PCA, right? Third nerve, PCA, cerebral peduncle, they are all closely related. You cannot study anatomy individually. All of it is connected. If you end up forgetting the orientation, then it's going to be difficult to apply it clinically. It will just remain in the books. So while we are looking at all these dissected images, we need to remember what other structures are not visible here. Let me draw this. So on this side, we are going to have the third nerve as well. PCOM is also going to go through this region closely. PCA is also going to be here. Uncus is here. This is the posterior segment of uncus. This is the anterior segment of uncus. Anterior segment is related to the anterior perforating substance. Posterior segment is related to the cerebral peduncle. It's not labeled here, but it's a pretty obvious structure, hard to miss on a dissection, right? So if we cut this uncus off, what is going to be underneath? This is the medial most portion of the temporal lobe, right? So what is in the depths of the temporal lobe medially?
The hippocampus, the
Brilliant.
hippocampus.
We are going to find hippocampus and amygdala. Uncus is the superiormost cortex. It's the cortical layer. If you peel it off, in the depth, we are going to find the hippocampus and the amygdala. So let me clear all of this. Coming back to the Sylvian fissure, we have the olfactory striae anteriorly. Posteriorly, we have the optic tract. Here we have the
Hippocampus.
uncus. Yes, the
Yes.
anterior segment. Please mute yourself. And somewhere around here, we are going to have the lemon insulae. It's not visible here in this section, but lemon insulae is going to be here. So now can you imagine why they are calling the sphenoidal segment a box-like segment? It's like a box. It has an anterior limit, a posterior limit, a medial limit, lateral limit, and then the roof is going to be formed by these olfactory in the orbital gyri. The floor is going to be formed by the temporal tip, planum polar. Am I clear so far?
Yes.
So once we retract this region here, you see this is the temporal lobe. Once we retract it here, this depression, this Sylvian cistern is going to continue laterally. Let's move on to the next image. Now you can see that it's a slightly unilateral vision, but it's the same region. This is the optic nerve. This is the optic chiasm. Posteriorly, we have the optic tract. Here we have the olfactory bulb and the orbital gyri. This is the anterior perforating substance. Uncus has been peeled off here. So what do you see? You are going to see amygdala. Uncus was somewhere here. And what is this structure? Cerebral peduncle. It's not labeled, but it's very visible. This is peduncle here. The uncus has been peeled away. You see the amygdala, and you also see the lemon insulae. And if you concentrate here, I'm going to clear this, then this cavity-like structure is continued laterally as well. And this is where on the other image you can see it's the same thing. And then this is getting continued here and here and here. So this entire cavity is filled with CSF and the arachnoidal layers. And this is what we call the Sylvian cistern or the Sylvian fissure. The stem of the Sylvian fissure is somewhere here. And it ends here when it reaches the lateral surface. Am I clear so far? We discussed this briefly yesterday, but I wanted to make sure all of you were very clear. So this was the sphenoidal segment here. This is the insula now. If I am let me change the color. This is the insular surface. And these are the opercular surfaces. This is the frontal opercula. Inferiorly, we have the temporal opercula. So, are you clear now what happens once we retract both of the operculi? We are going to see insula.
Yes.
Yes, ma'am.
And this region is the boundaries, the blue, the green, the light green, and the orange. This region is the operculo-insular part of the Sylvian cistern. This parrot green part is the sphenoidal segment. Let me label it so that you do not confuse it. This is sphenoidal segment, and the segment that is inside, this here is the operculo-insular segment. Now, the operculo-insular segment is divided in two parts. It's easy to understand. Between these two lips, there's the opercular part. This is the opercular part. Whereas on the insular surface, this is the insular part. All of this is just a communication of CSF and the subarachnoid space. Easy to understand, right? Let me move to the next image. You see another view of a cadaveric dissection. This is the inferior surface of the brain and optic nerves, optic tracts, optic chiasm. This is the anterior perforating substance. This here is the uncus. Somewhere here is the lemon insula. And this region is the sphenoidal segment of the Sylvian cistern. Let me go back. We missed a very interesting structure. So what are these?
Mammillary bodies.
Mammillary bodies. And what do we do here?
Third, ETV.
ETV. ETV.
Brilliant. So this is the location of ETV. This is how it looks from the inferior surface. I wanted to show it, but I forgot. Still. Now, if you follow the MCA here, MCA marks the Sylvian fissure. It's easy to understand in the proper dissection models where the vasculature is intact because you can understand how the MCA is following. And once you understand the MCA, the Sylvian is really easy to understand. You see that all this region that we covered, the sphenoidal segment, this is getting crossed by MCA. And then somewhere around here, there is lemon insula. At lemon insula, MCA either bifurcates or trifurcates. And then it moves into the opercular and the insular segment of the Sylvian cistern. We are clear so far, right? This is easy to understand, nothing too difficult. This is just another view of the same structures, but this clearly shows how the Sylvian cistern goes in communication, and you can follow the MCA visually, and you can see how this entire region is connected. ICA was somewhere here, which has been cut off. Around the ICA, there is going to be carotid cistern. And then from the carotid cistern, it's going to continue laterally, the Sylvian cistern, sphenoidal segment. Then here, the operculo-insular segment. This is in relation with the bony anatomy because a lot of you had a difficult time understanding yesterday the relationship of bone and the skull base with the Sylvian fissure and with the temporal anatomy. So what you see here is, this is planum polar, by the way, I forgot to mention. Planum polar is where the MCA traverses the temporal lobe. This region is planum polar. If we strip the MCA away, there's going to be a flat surface on the temporal lobe. There's going to be depression. That region is planum polar. It formed the floor of the Sylvian cistern. The roof was formed by the orbital gyri here. This is the anterior cranial fossa. Posteriorly, we have the middle cranial fossa that you cannot see the base of because the brain is left inside too. And you can see how it is following the lesser wing of the sphenoid. And Somewhere here are going to be the anterior clinoidal process. Is this anatomy clear now? Are you people here or am I not audible?
Yes.
Audible.
Okay. So this is another cadaveric image. It's the same thing over and over again. You can see how the skull base is in communication here. This is the ACP. And interestingly, what else do we have here? We have the anterior Sylvian point. We are going to discuss this today in detail. The anterior Sylvian point, you can see the MCA coming out. And once we open this up, once we put the retractors, we can follow the MCA inside. So let's see here. This is the superior temporal gyrus. And then we have the Heschel's gyrus. Heschel's gyrus and superior temporal gyrus form parts of the primary auditory cortex. Temporal horn is visible here. This is the temporal stem, this region. This is the temporal stem. This is the planum polar. If you remember the MCA was traveling on the temporal lobe somewhere around like this, right? So this depression, this plane surface is called planum polar. It forms the floor of the sphenoidal segment. The anatomy is it's very brief. The only reason I put in so many images is, so to build this visual library so that you can imagine it in 3D. And you can see again, they have cut off the temporal lobes here and anterior perforating substance in this portion, which is the Sylvian fissure. Let's not go into detail again. Moving on, it's the same thing over and over again. So I'm not going into detail. Opercular insular compartment, we have done the boundaries very clearly. Tulips of frontal, parietal, and temporal lobes. Insular part is between the opercular and the insular surfaces. It's the same thing. This is just an illustration. We see the insula here. And this is, let's see which side is which. I'm not sure which is the frontal, which is the temporal, but you get the gist. Also, since the insula is visible, you can sort of see the basal ganglia from here. So the transsylvian, transinsular corridor goes like this. Please mute yourself. Who's this? Let's move on to the next image. So the CT is here so that you can have a very clear idea. Even on the axial sections, it's easy to identify on the coronal sections, but on the axial sections, what is this region? Which segment is this? And which is this?
Insular segment and also opercular.
That's right. So you cannot see the sphenoidal segment here. All you see is the opercular insular segment. This one above is the opercular. And this one here is the insular segment. On. I think we have another image. There are some new joinees. Please mute yourself. So this is another illustration of the Sylvian fissure on a CT brain. And since the previous one was clear, I'm 100% sure this is also clear. This tree, a rough illustration of tree-like structure, this is the insular segment, whereas this horizontal limb-like thing is the opercular segment. The insular cleft, it can be divided in a superior limb and an inferior limb. Very easy to understand. Let's see this on the image. This is a coronal section because you cannot see the superior and the inferior limbs on an axial section. It would be really, really difficult. We draw here. These are the operculi, the parietal operculum and the temporal operculum. This is the opercular segment. Then we go behind like this. This is the insular surface here. And this is the superior limb. This is the inferior limb. Is it clear? What sulcus is this? It's marked. Oh, it's marked. What sulcus is this? What is the sulcus that overlies the insula? Are you with
Circular
me?
circle.
Circular sulcus. It was labeled. So this is circular sulcus. The superior portion of the circular sulcus, it is going to help make the superior limb of the insular segment. The inferior portion of the circular sulcus is going to make the inferior limb of the insular segment. All of it is connected. Do I need to go over this image? No? This was here to mention the operculoinsular segment. It's the same thing again and again. There's not much of a new thing to discuss. So we move to the anterior Sylvian point. Why is it important? Because it's a very important landmark for a lot of surgeries. It's usually when we draw the orbitomeatal line, which is from the lateral canthus, right, lateral canthus to the external auditory meatus, we draw a line. And on that line, approximately around 4 centimeters anterior to external auditory meatus, you're going to find the anterior Sylvian point. If you're marking it on a patient before the craniotomy. But you can see that this is anterior Sylvian point. It's interesting because this is also the meeting point of all these rami. This was the posterior ramus. This was the anterior ascending ramus. This was the anterior horizontal ramus. So the meeting point, it demarcates the anterior Sylvian point. It serves as the pathway for MCA. It also serves as the pathway for insula as well. We move. There's a ducting. This is a landmark in the anterior temporal lobectomy. If you're doing an anti-epilepsy surgery and you're going to take the temporal lobe tip out, then the anterior Sylvian point serves as a demarcation. Usually we try to stay anterior to this portion because posterior to this, we end up risking the eloquent regions and the temporal horn, etc., etc. The Mears loop, the temporal horn, and the eloquent regions, the auditory cortex, etc. So anterior Sylvian point is a landmark in the anti-epilepsy surgery, and it's important to demarcate where this is. And also, I did mention that this is the gateway for the insula. So once we open it, Lemon insula lies 1 to 2 centimeters in the depth. The M1, M2 bifurcation is also located. This is the region which also guides the Sylvian transinsular approach to reach the basal ganglia, the internal capsule, and sometimes thalamus. Thalamus is slightly inferior to this. The thalamus is slightly inferior. Otherwise, if you go directly, you're going to land at basal ganglia. So there are a few interesting papers that I came across while I was doing some research for these sessions. I have included the link here in the PPT. Now they are dividing the anterior Sylvian point morphometrically, and there are 3 types. There is nothing significant apart from the distance. The distance means the ease of opening up the arachnoid region. Type A is it's less than 5 mm. Type B is between 5 to 10 mm. Type C is more than 10 mm. If you remember it, fine. If you do not, that's completely okay. It's a new literature. I am going to share the link on the group directly as well. So you can see that this is the posterior ramus, and this region is the anterior Sylvian point. Type A, you do not see a lot of distance between them. The distance is less than 5 mm. Then we have type B, where the distance is between 5 to 10 mm. So it's easier to open. And type C, there is a wide distance, usually more than 10 mm. Hence, the arachnoidal dissection is really, really easy. This is another image of the same thing. You can see the lips are literally meeting here, the temporal and the frontal operculi, whereas here you see the distance. Anterior Sylvian point is also demarcated sharply by pars triangularis. If you look at the position, the pars triangularis tip, it points to the anterior Sylvian point. This is the pars triangularis, and this is where the anterior Sylvian point is. Type B, 5 to 10 mm. Type C, more than 10 mm. That's all for today. I think we did cover Sylvian Fissure in as much depth as possible. It's very easy. If there are still questions or any feedback, you're more than welcome. Also, if I make any mistake during the session, you can completely let me know. That's perfectly fine. Do we have any questions? No questions? Either you people have understood every single thing or you haven't.
Madam, if we do epileptic surgery for the anterior temporal lobectomy, will it contain the plenum polar also medially?
Plenum polar, I am not 100% sure about this. So I would rather go back and check and then let you know.
Okay.
Because plenum polar is also going to have MCA around it. I'll check and I'll let you know on the group. You are on the group, right?
Yes, ma'am.
Okay, I'll let you know on the group.
Okay.
Do we have any other questions? Okay, Dr. Rahul, we are going to have separate sessions for Sylvian Fissure splitting because you cannot understand the splitting unless you understand the anatomy. It would have been really, really difficult. Let me ask Dr. Itzaz if he would be able to do the Sylvian Fissure splitting tomorrow or day after tomorrow, and I'll let you know on the group. Any questions regarding the anatomy, etc.? No? Okay, then this is a wrap. Thank you so much, everyone. I leave the recording on the group and paper link of Sylvian types. Yes, I'm going to share the link. It's in the PPT. I'm going to upload the PPT on the drive, and I'm also going to leave the link as well. Thank you so much, everyone. This is a wrap for today. See you all tomorrow.